Jai Hind, and a good day to all the viewers. First, before starting my seminar, I would like to play a video.
I've been thinking, I want you to be happier. I want you to be happier. When the morning comes and we see what we've become. In the cold light of day, we're a flame in the wind of the fire that we begun. Every argument, every word we can't take back. Cause with all that has happened, I think that we both know the way that the story ends. Then only for a minute, I want to change my mind. Cause this just don't feel right to me. I wanna raise your spirits, I want to see you smile. No, that means I'll have to leave. No, that means I'll have to leave lately.
So, the most prominent expression of joy is a person's laughter. A sparkling smile, in coherence with lips and face, reflects a person's character and life. If you want to be able to smile freely without thinking about the appearance of your teeth, the veneers could be the answer you're looking for. With this, I, Afifa Rasheed, from the Department of Prosthodontics in Crown and Bridge from Subharti Dental College, am here to present my seminar on laminate veneers. I shall be covering my seminar under the following contents. Now, what are these veneers that has piqued everyone's interest these days? According to Student, a veneer is a tooth-colored material that is applied to the tooth to restore localized or generalized effect and intrinsic discolorations. According to the glossary of prosthodontic terms, it is a protective or ornamental facing, or a superficial or attractive display in multiple layers. Let me take you a few years back and discuss an interesting history behind these veneers. Back in the day, it was necessary for the celebrities to have a glamorous smile, which was brought about by Dr. Charles Pincus in 1930s. He developed a thin facings of air-fired porcelain, which were temporarily held in place with adhesive denture powders, and this was popularly termed as Hollywood smile. After a few years, in 1955, Bruno Core, he introduced an acid etch technique to increase the adhesion of acrylic filling material to enamel, which led to an important aspect in the molecular dentistry, which is known as bonding. After that, in 1958, Bowen led to the development of filled resin, which enabled mechanical bonding between etched tooth and filled resin. And in 1975, Rasheed introduced the use of silane coupling agent with porcelain laminate veneers. So, in the early 1980s, the key pioneer in American laminate dentistry were instrumental in the development of porcelain veneers and the techniques. Now I shall be telling you where these veneers are used. The foremost indication of the veneers is in cases of extreme discolorations due to many factors such as tetracycline stainings. It can also be used in diastema or minor spacings, in cases of worn or fractured teeth, malpositioned teeth, or in patients with poor anterior restorations. They are contraindicated in cases where there is insufficient crown material, poor periodontal health of the patient, in cases of deep bite, severely fluorosis teeth, patients with poor oral hygiene, and parafunctional habits like bruxism. Now let's classify these veneers. Based on the mode of fabrication, the veneers can be classified into direct and indirect veneers. The direct veneers are made intraorally, and indirect veneers are fabricated in the lab after making the impression. Based on the material, these direct veneers are made of composite, and for indirect veneers, porcelain and composite are the material of choice to fabricate them. Based on the extent of preparation, these veneers can be classified into various designs. First is the window preparation, feather preparation, incisal bevel, and incisal overlap. Now, these veneers can also be classified based on the processing technique. They can be classified into feldspathic porcelain veneers, CAD/CAM system veneers, or heat pressed glass ceramics. I shall be discussing in detail about all the materials that are used for veneering. I will be starting with composite veneers. The composite resin veneers, they are composed of three components: a highly cross-linked polymeric matrix which is reinforced in the resin filler particle which are bound to the matrix by coupling agents. These composite has an advantage of that they are made in wide varieties and consistencies and shades. They are convenient to manipulate and are custom made according to the patient's needs. As porcelain veneers are fabricated in the laboratory, it has a superior qualities, giving it a more natural tooth-like appearance. The preparation done for it is conservative and the material is resistant to stains. But the procedure is time consuming and has a poor marginal integrity. When comparing porcelain with composite, color stability, bond strength, and the fracture resistance is more than composite, whereas composite have the tendency for micro leakage. Therefore, porcelain is always preferred over the composite veneers. Now, some details about the direct and indirect veneers. Starting with the direct veneers, the direct veneers are used when a small number of teeth are involved or there is localized intrinsic discoloration. The advantage of using direct veneers is that it can be done in a single visit. If the restoration is chipped off, it has the potential to repair and the preparation done is conservative. But the disadvantage is that it is time consuming and labor intensive. Now, the indirect veneers are processed in the laboratory to achieve superior properties and are of two types: processed composites and porcelain veneers. The processed composite has a superior physical and mechanical qualities than the chairside composites. So, they are processed under intense light, heat, vacuum, or pressure. The processed composite are indicated in cases of diastemas, enamel hyperplasias, and mild fluorosis. Now I shall be discussing in detail about the feldspathic porcelain veneers. As the name itself says, the feldspathic veneers are composed of feldspat, quartz, kaolin, and the basic component being silica dioxide. They are fabricated using a layering technique, which means that the technician has a full control over the layers, which makes it highly aesthetic, but due to its low mechanical properties, it has least strength and is resistant and is prone to fracture. As the layering technique was time consuming and technique sensitive, to overcome these problems, machinable feldspathic ceramics are now used. Currently, computer-aided design and computer-assisted manufacturing system is being used, which makes veneer construction easier, giving it a natural appearance. It's time-saving but comes with a high cost. Now, the heat-pressed glass ceramics. Improvement in the properties of these laminate veneers depends on the crystal interaction and the glassy matrix, and also on the porcelain crystals, their amount and size. By adding certain types of fillers such as leucite, lithium disilicate, or zirconia that are uniformly dispersed throughout the glass, it increases the strength of the glassy ceramics that we achieve. Now, for the placement of direct as well as indirect veneers prior to the tooth preparation, shade selection is done. Now, shade selection is an important step in the veneer preparation. Correct shade selection is vital to the success of the veneers. It is to be done prior to the preparation of the tooth. There are various factors that affect the shade selection. Firstly, being the lighting of the operator room, which should be color corrected or natural daylight. The shade selection should never be done on a dried tooth as it appears whiter when dried, and isolation by cotton roll and rubber dam should always be avoided. Stains and plaque on the surface of the tooth should be removed before the shade selection, and color acuity and color fatigue, which results from staring at an object for a longer duration of time, should be avoided. Now, for the tooth preparation, there are various steps. Firstly is the labial reduction, then incisor, interproximal, and then the cervical reduction. A veneer preparation kit is being used for preparing, finishing, and polishing of the tooth. Starting with the preparation of the labial surface, there are three techniques for the preparation of the labial surface. The first technique is the use of depth cutter burrs. These depth cutter burrs come in two sizes, first 0.3 millimeters and 0.5 millimeters. Another technique that we use is freehand technique. It is used by some highly experienced and well-trained operators in which no depth cutting preparation guidance is used and it depends upon the tactile sensation. The third technique is the use of silicone putty index after wax up, which may be helpful for guiding the surface of labial surface reduction. The second, after the labial reduction, we prepare the incisal edge. So there are various preparation designs that are being used for reduction of the incisal edge. Firstly, being the window preparation. The window preparation is in window preparation there is minimal to preparation, and it is done up till the incisal edge, but the incisal edge is not being prepared. It is done in cases where the patient suffers from stains and discoloration and the crown length correction is not required. The second incisal edge preparation is feather preparation, in which the incisal edge is the preparation is prepared up till the incisal edge. This type of preparation is being used where no crown length correction is being required. The third type of preparation is incisal bevel type of preparation. In incisal bevel, the incisal reduction is done for about 0.5 to 1 millimeters, and it is done in cases of fractured or worn out teeth. Incisal overlap type of preparation, it is done for fractured incisal angles or in cases where we need to increase the length of the tooth. The incisal preparation in incisal overlap is done for about 2 to 4 millimeters. After the incisal edge has been prepared, then we prepare the interproximal surface. There is no restricted role regarding the interproximal tooth preparation for veneers. Therefore, no preparation is required, especially for the window type of preparation. A conservative interproximal preparation is done where no contact areas are open. But in cases of diastema closure, we prepare the tooth more interproximally to maintain the aesthetics. In some situations, when preparing multiple teeth with tight contacts, breakage of the contact may be advisable in order to freeway the contacts. Then we prepare the cervical margins. Now the cervical margins is one of the critical area for aesthetic and biological point of view. Finishing lines may be at three locations. It might be supragingival, adgingival or subgingival. Now the supragingival finish line are more hygienic for biological point of view, but they are less aesthetic. It is preferred to give a chamfer finish line, and it is acceptable by the ceramist as well. Now, a preparation of a subgingival finish line may be achieved by gingival retraction cord so as not to jeopardize the gingival tissue. This type of finish line is highly aesthetic, but it is not good for the gingival tissues. Now, during the preparation, certain measures to be taken care of are: the preparation should be as conservative as possible. It should allow for covering of 0.3 to 0.5 millimeters of veneer material required. While preparing the tooth, it should not penetrate the dentine, and adequate clearance should be present interproximally. The preparation should always allow for cleansable gingival margins. It should not include any sharp angles. The preparation should have a path of insertion which is free from undercuts, and a definite finish line should be prepared for accurate placement. Now, a study was done, a meta-analysis of a most indicated preparation design for porcelain laminate veneers, which concluded that the incisor bevel is the type of preparation that least affects the strength of the tooth, and the overlap type of preparation is more susceptible for ceramic fractures. There was another study on the survival rate of porcelain laminate restoration based on different incisal preparation designs. It was concluded that in window preparation, 11% of failure rate was observed, and the most common type of failures were seen as interfacial staining and debonding of the veneers. Now, to brush up all the steps of tooth preparation, I would like to show a video here. Firstly, the depth of the preparation is marked and prepared by depth cutting burrs from the labial surface as well as from the incisal surface. Then, using a pencil, we mark the depth cuts and then evenly reduce the preparation from the labial side as well as from the incisal side, for which we use a red color coded round end tapered burr. After the labial and the incisal surfaces are being prepared, we extend the preparation interproximally. Here, the tooth is being prepared under higher magnification, and then the cervical margin is being prepared. After that, we place the retraction cord and then we smoothen out the preparation from all the surfaces of Then, using a double retraction cord, we make the impression by one-step impression technique. The cementation. The cementation is done in two steps. First is the temporary cementation and then the permanent cementation. Now, temporary cementation is an integral part of treatment to give a preview of final restoration. These pastes are available in different shades and values. Now, through an analysis of color obtained with the clear paste, the need of increasing or decreasing the value can be seen by using a whitish or a yellowish paste that are available. The temporary cementation is done by the trying paste, which are water-soluble material that are used to guide the dentist in the selection of the shade required for the final cementation. Now, they come in various brand names such as Variolink Aesthetic Trying Pastes. Now, there was a study on an investigation into the effect of drying paste, uncured and cured resin cement on the overall color of ceramic veneer restoration, an in vitro study in which they concluded that the clinically significant difference were found between the drying paste and the cured resin of the same shade. However, there were relatively small changes measured between uncured and cured resin. Coming on to the final cementation, the final cements can be classified based on the resin-based luting materials. They can be chemically activated, light activated, or dual cure activated. These cements come by various brand names. Now, I'll be quoting various studies in which I'll be discussing different properties of different cements. First is the color stability of ceramic laminate veneers cemented with light polymerizing and dual polymerizing luting agent, a split mouth randomized controlled trial study in which they concluded that dual polymerizing resin cement undergo greater color alteration than light polymerizing resin cements. On the color stability and opacity of resin cements and flowable composite for ceramic veneer luting after accelerated aging, it was concluded that virulent veneer, which is a light cure cement, showed higher color stability than the other tested materials. On the micromechanical properties of veneer luting resins after curing through ceramics, they concluded that the dual cure resin cement expresses better performance than the light cure cements. The shear bond strength of porcelain laminate veneers to enamel, dentine, and enamel dentine complex bonded with different adhesive luting cements concluded that the type of resin cement, that is dual cure or only light cure, did not affect the shear bond strength of the porcelain laminate veneer restorations. A study on the volumetric shrinkage and film thickness of cementation material for veneers was done and then concluded that the virulent aesthetics has the lowest volumetric shrinkage of about 1.3%. Now that we know how to select the cement, after that we need to prepare the veneer, and then we need to prepare the tooth before cementation, and then we place the veneer over it. Now for the cementation, selection of the cement, the higher the translucency of the resin cement, the more natural the appearance. So we prefer light activated resin cements because it has a longer working time, increased color stability, and a longer shelf life. So after a correct shade of the cement is being selected, we prepare the veneer. The veneers are conditioned firstly with a 9% hydrofluoric acid for 60 seconds. It's washed with running water for 20 seconds and dried, followed by a layer of silane coupling agent, and then a hydrophobic adhesive is being applied over the veneer surface. Etching time by hydrofluoric acid might differ according to various veneering materials that are being used, such as for feldspathic ceramics it is 120 seconds, for lucite it is 60 seconds, and for lithium disilicate it is 20 seconds. Now here is a table that shows different adhesive systems that are being used for the bonding of enamel or enamel and dentine. After we know how the veneer is being prepared, we should know about how the tooth is being prepared and how the veneer is placed over it. For that, I'll be showing a video. Firstly, the isolation is done with the help of a rubber dam, and then we try out the veneers over it. Then we clean the enamel surface before etching, and the etching is done on all the surfaces of the tooth for 15 to 20 seconds. After that, it is being thoroughly washed and dried off for 30 to 40 seconds. Then two successive layers of adhesives are being applied with the help of brush to all the surfaces. And then the veneer is being cemented over to the tooth. Then with the help of flash curing, excess of cement is being removed by a 12 number surgical blade. After the excess is being removed, then we apply a layer of glycerin and curing from all the surfaces is being done. Then we check for the occlusion and trim off excess cements. As we all know that veneers can be customized, little is known that veneers also come in prefabricated form, which comes by the name of componeers. Now these componeers are a relatively new system known as the same day veneers. They are polymerized, prefabricated nanohybrid composite enamel shells that combine the advantage of direct composite restoration with the advantage of lab-made veneers. They come in different shades and different sizes. The advantage of these componeers is that they can be easily and quickly fitted, they are easy to clean and require minimum tooth preparation, but they are weaker than the traditional veneers, decrease survival rate and are less resistant to stains. For the maintenance of these veneers, for the first 72 hours, we ask the patient to maintain a soft diet and avoid any hot or cold beverage. In the regular follow-up, we evaluate the veneers, check the gum tissue response, and a routinely 4-month scaling is required. The oral hygiene instructions given are of regular brushing and flossing and the use of non-abrasive fluoride toothpaste. Despite the success in the veneers, the final outcome, that are the failures in the veneers, may involve errors in the rehabilitation planning or during fabrication, during the technique or in the maintenance of the veneers. Now, there are various factors which lead to the failures of these veneers. Some of them can be during the planning of these veneers by the lack of clinical consistency or improper decision by the clinician or the patient. Other factors can be due to fabrication or during the technique of the veneers. Or sometimes failures of veneers might be because of the maintenance, in which sometimes recurrent caries might occur or there can be micro leakage. Now there have been a systematic review and a meta-analysis done on the survival of ceramic veneer made of different material after minimum follow-up of 5 years, which concluded that the ceramic veneers fabricated from feldspathic or glass ceramics have an adequate clinical survival rate of at least 5 years with very low complication of up to 9%. Another study was done on the evaluation of marginal internal adaptation of CAD/CAM and pressable ceramic veneers of different preparation designs, which concluded that the pressable ceramic veneers with overlapped incisal reduction design produced a higher marginal gap. Some of the recent advances in the veneers are the use of luminaires. Luminaires are made from a special patented Cyrenite porcelain that is very strong but much thinner than the traditionally fabricated veneers. Their thickness is comparable to a contact lens and minimal to no preparation is required. There is no need of any temporary restoration and it is very comfortable for the patient. The advantage of using these luminaires is that it is a minimally invasive technique and these luminaires are strong and durable and natural looking. But it is not indicated in all the cosmetic procedures and only the teeth who are structurally sound and good can be used for these luminaires. Another advancement is the use of pro veneers. They are direct veneering system in which they are custom made in the office and it fits to the exact margin of the tooth. It has made the cosmetic dentistry easier and better. The main advantage of these pro veneers is that they are lab-free veneers and they preserve the natural tooth structure. They can be easily used and require minimal chair time. But in some patients, there have been reported sensitivity to this product. To conclude, many dental patients desire smile enhancement procedures that are less invasive. To overcome that, laminate veneer remain as prosthetic restoration that best comply with the principles of present-day aesthetic dentistry. By understanding sound principles, selecting the right dental material, and applying proven techniques, we can deliver predictable and natural life-looking enhancing treatment for our patient. These are my references. I would like to acknowledge and thank our principal, Dr. Nikhil Srivastava sir, for giving me this opportunity to present my seminar. I would also like to thank my head of the department, Dr. Roma Goswami ma'am, my guide, Dr. Dipesh Saxena sir, and my co-guide, Dr. Sumit Agarwal sir, and all the faculty members for their continuous guidance and support. Thank you.